my new experience for me that I am talking to you people without seeing you. Anyway, thanks Teleradiology for giving me this opportunity. Today I'll be talking about spinal dysraphism, which is the congenital malformations involving the spinal cord. Especially, I will be talking about the spinal cord and its associated anomalies. So in this talk, I will be covering the embryology, the various classifications that we follow, the open spinal dysraphisms and the closed spinal dysraphisms, which is the grossly they have been classified as. To understand any dysraphisms, that is, dysraphism means false suturing, means the suture which is done embryologically has not gone in a right manner. So when it is not gone in the right manner, it is called as a dysraphic spinal anomalies. So to understand that, we need to know about the embryology. Without the embryology, there is no point in discussing the spinal dysraphisms. So I will be talking about the embryology first, then subsequently it would become very easy for you people to understand each malformations that happen. Coming to the embryology as such, there are three relevant embryonic steps that are involved in the development of the spinal cord and its associated coverings. One is the gastrulation, which happens around 2 to 3 weeks of the and second, hello, hello, hello. First process is the gastrulation, which happens around 2 to 3 weeks of gestation. Second is the primary neurulation, around 3 to 4 weeks of the gestation, and third is the secondary neurulation. But all these things will be happening simultaneously in an overlapping manner. So first, coming to the gastrulation, as you all know, the gastrulation is a terminology that is used for where a bilaminar embryonic disc becomes a trilaminar amniotic disc. After the formation of the zygote, we all know the zygote gets itself implanted into the uterine wall. There will be syncytial trophoblast, there is a cytotrophoblast which is towards the embryo, and syncytial trophoblast that is towards the uterine wall. There, when it gets implanted, the inner cell mass are arranged in two layers. Those two layers, they form the bilaminar disc. The superior one that is going towards the yolk sac, that is the one, this is the one which is towards the amniotic cavity. It is called as the epiblast, which is the future primitive ectoderm. And the one that is towards the yolk sac is the hypoblast, which forms the primitive endoderm. So this is the bilaminar disc. When it gets implanted, this is the uterine wall. Through the cytotrophoblast, it is getting implanted. When the bilaminar discs are there, it becomes a trilaminar disc in a subsequent process, and the formation of the trilaminar disc is called as that process is called as a gastrulation. So what happens in during the formation of this trilaminar disc? This epiblast in its central part forms a primitive streak. This is the primitive streak. Primitive streak is nothing but the thickening of these cells, which extends from the caudal neuropore towards the center. This is the buccopharyngeal membrane. This is the towards the cranial end. This is the caudal end, and from the caudal end, this primitive streak extends towards the buccopharyngeal membrane. And the cranial part of the primitive streak, the cells are more thickened. They are called as the primitive node or the Henson's node. A tip appears at the level of the primitive node, and that is called as the primitive dip. So this primitive node and primitive tip is very important, because the epiblastic cells, they with the influence of the fibroblastic growth factor, which are secreted by the hypoblasts, with the influence of that, these epiblastic cells, which are arranged towards the yolk sac, towards the amniotic cavity, they form a furrow, they come inwards and go exchange, they migrate themselves so that they come in between the hypoblast and the epiblast. So this is how it happens. I will show you. See, this picture explains you that this is the primitive streak and the primitive node, and in this primitive node the epiblastic cells, they thicken themselves and they migrate towards the center, and they go furrow themselves inwards so that they themselves get placed in between the epiblast and the hypoblastic cells. So this formation of these separate layer of the cells are not, this is the primitive mesoderm. So the formation of the mesoderm is the conversion of the bilaminar disc towards the trilaminar disc. There is one more important part that happens is this primitive node, which has a primitive pit with that remains open, and it will be communicating with the yolk sac, with the amniotic cavity. So the central part of this mesodermal layer, they get thickened themselves and they form the notochord. So there will be two notochords initially. One is towards the right and one is towards the left. They fuse together in the center so that they form a definitive notochord. In the early stages, this notochord will have a canal within it, which it will be, there will be a canal. This canal is called as a notochordal canal. That canal communicates superiorly with the amniotic cavity through the primitive pit, and inferiorly it communicates with the yolk sac. So this communication will be there for a 1 or 2 days, up to 8 days. So this is called as a primitive neuroectodermal canal, notochordal canal. So this primitive neuroectodermal canal, if it persists for a longer time, then it gives rise to the so many anomalies which I will be telling you the later. Okay. So after the formation of this definitive notochord, notochord forms here. This is the mesoderm, and the mesoderm will be interposed between the epiblastic cells and the hypoblastic cells. So these epiblastic cells, they are the ones which are going to form the central nervous system. So this is the initial stage, that is the gastrulation. Following the gastrulation, there is a process what is called as a primary neurulation. In the neurulation, what happens is the epiblastic cells, they form the neural plate. They become thickened and they form the neural plate. This neural plate, this is the neural plate, this is the notochord. Under the influence of notochord only, this neural plate forms. This neural plate, this cells, we should know before this that the primitive ectoderm is destined to form the neuroectoderm, means it is destined to form the neural tissue. Apart from that, under the influence of the BMP proteins, that is the bone morphogenic proteins, this neuroectoderm give rise to the formation of the epidermal tissue. Epidermal, as you know, this is also a ectoderm, that is the skin coverings. They are actually primitively, they are formed by the epidermal tissue. They are formed by the primary neuroectoderm. This neuroectoderm give rise to the epidermal tissue under the influence of the bone morphogenic protein. If the bone morphogenic proteins are not secreted at that point of time, then we will have a huge brain babies. So without the covering of the brain, sometimes it happens. So with the influence of the bone morphogenic proteins, this primitive neuroectoderm give rise to the cells, that is the epidermal cells, which form the skin covering. So what happens during the primary neurulation? During the primary neurulation, as you know, this neural plate forms. This neural plate tend to fold upon themselves so that the folding approximates in the dorsal area. They approximate and they fuse together. So this is the neural folds. Neural folds are formed at the distal end of the neural fold. Here, it again fuses to form the primitive neural tube. This is the neural tube which is formed by the neuroectoderm. during that time, these epidermal tissues, they disjunct, means they separate from the neuroectoderm, and this epidermal tissue forms the skin covering, and in between that will be the interposed mesodermal cells, which will be forming the spinal spinous process, the muscle tissue, and other cutaneous other connective tissues which are there posteriorly to the neural tube. So this is the formation. This is the process of primary neurulation. This process of primary neurulation, that is the fusion of the uh, neural formation of the neural tube due to the fusion of the neural folds, is not a one process, means it doesn't just start at one level and proceeds to the other level. It will be happening simultaneously in a zipper fashion at multiple levels simultaneously. There usually they are considered at 5 places it starts and ends, so that they all fuse together simultaneously. So any problem that comes during the formation of this neural tube can give rise to the disorders which are where the fusion process are hampered, and the spinal means the posterior spinal process are not fused. So this is the one logical explanation for the why we see spina bifida, then open spinal dysraphisms like that, so on and so forth. Then comes the process of called as secondary neurulation and retrogressive differentiation. This is the formation of the spinous processes and spinal canals below the level of S3. After the 30-second somite, this whatever the spinal cord and its other associated structures are there, they are formed by the process what is called as a secondary neurulation. Here, the inner cell mass, they are actually the totipotential cells. They proliferate in such a manner that they form a secondary neural tube, which means they form a cell mass, inner cell mass, which actually canaliculates to form the secondary neural tube. This secondary neural tube communicates with the tube that is formed by the primary neurulation, so that the entire spinal cord will be present. So initially it will be a solid medullary cord, which will become subsequently cavitated. So this is the process of gastrulation initially, followed by primary neurulation, then the secondary neurulation. So this secondary neurulation, sometimes the slight expansion of the central canal will be there within the conus medullaris. This is where the conus medullaris comes, and this secondary dilatation is called as the terminal ventricle. Okay, before going to the pathology proper, we need to know one terminology, what is called as placode. Placode is nothing but a neural tissue which is non-neurulated. That means to say, embryologic primitive neuroectoderm is called as placode, that has not undergone the process of primary neurulation or secondary neurulation. So this placode is of importance as I am dealing with the various anomalies. So this is the secondary neurulation. This is that tail bud or the inner cell mass that forms. This will get cavitated, and this cavity will in turn communicates with the central canal. Okay. Now coming to the classification, there are various classifications that are applied. So each has the neurosurgeons, they have their own classifications. That depends depending on their management. Radiologists, they have their own classifications. The embryology, the anatomists, they also classify by their own way. But for us as a radiologist, we need to know the clinico-radiological classification. What does that mean? There are various things in that. One is the open spinal dysraphism and the other is the closed spinal dysraphism. This is the broad classification. So in the open spinal dysraphism, you can see the anomaly from outside. So in that category, the Meningocele, Myelocele or Myeloschisis, hemimyelomeningocele or hemimyelocele will fall into that category. Then there are what are called as closed spinal dysraphisms. In the closed spinal dysraphism, here the anomalous, these uh, pathologies are covered by the skin, subcutaneous tissue. Means the skin will be covering in the open closed spinal dysraphism, whereas they are open, means the skin covering will not be there in a open spinal dysraphisms. So this is a broad classification. In the closed spinal dysraphisms, there are two we are categorizing into. One is with subcutaneous mass and the other is without subcutaneous mass. I will be dealing with the open spinal dysraphisms and the closed spinal dysraphisms with subcutaneous mass in today's lecture, and subsequently I will be telling about without subcutaneous mass and other anomalies in the next class. So coming to the open spinal dysraphisms, as I told you earlier, myelomeningocele, meningocele or myeloschisis, hemimyelomeningocele or hemimyelocele. You need to know each terminology. Among this, the myelomeningocele is the most commonest and actually represents around 99% of the open spinal dysraphisms. So coming to the myelomeningocele, as I told earlier, there is a process of the formation of the neural tube. This neural tube will not be covered. So when they are not covering the entire posteriorly, when the neural tube is open, then it will give rise to the myelomeningocele. So the neural tube is not formed. Because the neural tube is not formed, then there will be no opposition of the overlying epidermal tissue. So the placode, this is what non-neurulated tissue, what I told, the placode, so which actually should have formed the central canal. If it had formed a neural tube, it would have formed the central canal. Since it is open, the central canal will not be there. So the lining of the central canal is actually open to the atmosphere, means the exterior. So the epidermal tissue will not be joining together to cover this placode. So the placode here, there will be thickening due to the formation of the neural folds. This neural fold will become subsequently various sympathetic ganglia or the dentate, various ganglia it can form. So here what happens, due to the non-fusion of non-formation of the neural tube, the placode will remain open to the exterior. This is called as the myelomeningocele. So in a myelomeningocele, it is due to the faulty neurulation process, probably caused by the lack of expression of the carbohydrates on the surface of the neurons in the developing neural tube. So the neural tube will not be exposed to the carbohydrates, and that in turn lead to the formation of the faulty primary neurulation. Apart from that, there will be faulty flexion and fusion of the neural folds to form the neural tube, lead to the persistence of the portion of non-neurulated neural tissue, what I told as placode. Okay, because of the risk of ulceration and exposing to the exterior, there is a risk of infection. That's why myelomeningocele is a neurosurgical emergency. As such, myelomeningocele can be diagnosed clinically. There is radiologically to diagnose myelomeningocele is not very useful, but there are associated anomalies. There are associated secondary things that can form due to the myelomeningocele. To imaging, to have an idea about those before taking the child for surgery, the imaging is required. So what are all those things? This can be diagnosed antenatally, wherein you can see the hydrocephalus. There is a lemon-shaped skull vault, and almost all the times, 100% of the times, there will be associated Arnold-Chiari malformation type 2 in these cases. That's why you can see the tactile beaking, and there may be associated clubfoot, which is diagnosed antenatally. And in in the postnatal imaging, this is the MR. You can see that there is a this placode. This is what I was meaning. This is the non-neurulated neural tissue directly exposing itself to the exterior. So this is what you will be seeing. But associated to it will be the Arnold-Chiari malformation, which is having means there will be a herniation of the tonsils lower down. That is one thing. The other thing is because this spinal cord is low lying and it is tethered posteriorly, there will be abnormal dynamics of CSF flow within the spinal cord, leading to the formation of the hydromylia. So this information you can get by doing a spinal imaging, especially the MR. So the role of imaging in a open spinal dysraphism, that is myelomeningocele, is one is to find out the associated anomalies like hydromylia, what is the degree of hydrocephalus that is there, and how much Arnold-Chiari malformation, this the herniation of the brainstem or the cerebellum or the tonsils are there, that you can get an information by do the imaging. The other role of imaging is the post-operative imaging. Invariably, after treating these cases with surgically, there may be recurrence of those symptoms, and they may be, this recurrence of symptoms may be secondary to retethering or leading to the low-lying cord. There may be a arachnoid cyst that has happened secondary to the surgery, or the implantation dermoids or the epidermoids, which can happen secondary to surgery, and the hydromylia. Hydromylia, again, due to the tethering, there will be abnormal flow dynamics of CSF within the spinal canal, leading to the formation, accumulation of the CSF either in the central canal or the in the spinal cord. Coming to the other entity is the myelocele or myeloschisis. It is similar to the myelomeningocele. The only thing is there will not be the CSF space that is be open that will be open to the outside. There will be thin skill covering. Here, what will be happening in the myeloschisis is the placode will be actually at the plane of the skin. So the placode will be directly seen at the plane of the skin, and there will not be any CSF tissue, CSF accumulation exterior to that. So this is what that happens in the myeloschisis. So what here the placode actually, which should have lined, this is lined by the central canal, that will not be there. These are all vascular zone, means usually the vessels will be seen at the cells which are lining the central canal. So medullovascular zone will be there at this level of the placode. So you may see a cherry red like placode at the level of the myeloschisis. So that is one imaging. This is the imaging of the same using the T1 and the T2 weighted images. So the associated anomalies, as you are seeing, there will be gross hydrocephalus. There may be interdigitations, stenogyria interdigitations, which of the gyri that will be happening at the supratentorial level. There is a herniation of the tonsils, as you are seeing in this case. Coming to the Arnold-Chiari malformation, I will just touch upon this because invariably in 100% of the cases there will be of open spinal dysraphisms, there will be associated Arnold-Chiari malformation. The reason for this is when the CSF is open to the outside, there will be drainage of the CSF, which normally should not have drained into those sacs of a myelomeningocele or to the exterior in a case of myeloschisis. So when they are draining outside, majority of the CSF, it will be like pulling the entire brainstem downwards along with the cerebellum and the tonsils. So because of that, there will be herniation of these structures. Apart from that, the cerebellum may be smaller in size, and there will be associated hydrocephalus or stenogyria as interdigitations of this one, and there will be alteration of the skull vault also, because the volume of the CSF will come down cranially. So because of these reasons, there will be associated anomalies with the uh, open spinal dysraphisms. The other thing is the hemimyelocele or a hemimyelomeningocele. This is similar to the what I described earlier, myelocele or the myelomeningocele. Only thing here, there will be splitting of the cord, so there will be associated diastometamylia. One arm of the cord may be normal, whereas the other arm of the cord may be associated with myelocele or hemimyelomeningocele. So one half of the cord will be normal, the other part of the cord may be associated with these anomalies, but these are extremely rare, and most of the times they are associated with, when they are present, they are hemimyelocele, not the myelomeningocele. Suppose if there is associated meningeal protrusion, the malformation is termed as hemimyelomeningocele. So this is one thing I have seen. See, you can see there is a splitting of the card, and one part of the card that is on the left side, means the laterally situated on the left side is the one that is having a myelomeningocele in this. So this is the same thing. There is a splitting of the cord, diastometamylia. The same, these images, the axial ones are represented here. So on the left side, you can see there is a dilatation of the central colon along with the protrusion of the meningeal protrusion outside the canal, giving rise to hemimyelomeningocele. But these are extremely rare anomalies. Whatever it may be, this information is given by imaging. Not We cannot get this type of information clinically. So this is regarding the open spinal dysraphism. So 4 points in the open spinal dysraphism. 4 entities come under that. One is myelomeningocele, the other is myelocele or myeloschisis, hemimyelomeningocele or hemimyelocele. So these are the 4 entities. Coming to the closed spinal dysraphisms, these are the ones which are associated with subcutaneous mass, and the other are not associated with the subcutaneous mass. The one which associated with the subcutaneous mass, you can make out with the mass. The other entities may be associated with dermal nevus, or a hirsutism may be there focal at the level of the defect, or there may be a hemangioma associated with it, and there may be associated dimple or the sinus, dermal sinus, that may be associated with it. So like this, those are the entities which are not associated with the subcutaneous mass. The one with the subcutaneous mass, there are various entities within that, but these are usually seen at the lumbar level. So when they are associated with the subcutaneous mass, this mass is usually located above the intergluteal cleft. So this is a important information, because the one which are situated below the intergluteal cleft can be seen in the caudal regression syndromes, or in sacrococcygeal teratoma, where you can see some mass there also, but they are located below the intergluteal cleft. So the one with the closed spinal dysraphism with subcutaneous mass, this mass is seen either to the left or to the right, but above the intergluteal cleft. So the entities which are included in that are the lipoma with the dural defect, where lipomyelocele or lipomyelomeningocele. The other things are the myelocystocele, which can be terminal or non-terminal, and the meningocele. So I will go to each entity now separately. Now coming to the lipomyelocele or lipomyelomeningocele, or the lipomadural defect. Let us go back to the embryology. As I told earlier, this is the formation of the neural tube. So when the neural tube is forming, before the fusion of these neural folds, that is before the formation of the neural tube itself, when there is disjunction of the ectoderm, this is the epidermal tissue from the primitive neuroectoderm. When there is disjunction of that, then the mesenchymal tissue can enter in between that. So when the mesenchymal tissue enter, the neural fold, they have not fused, but the mesenchymal tissue has already entered and the epidermal tissue is already closed. So that is where the lipomyelocele or lipomeningocele will happen. That means early non-disjunction, early disjunction early disjunction of the epidermal tissue from the primitive neuroectoderm will give rise to the lipomatous tissue. So mesenchymal tissue will give rise to the lipoma. So if this mesenchymal tissue enter the um, neural tube, then it will give rise to the lipomyelocele or lipomyelomeningocele. So early disjunction of the epidermal tissue from the primitive neuroectoderm will give rise to the formation of the lipomatous tissue because of the entry of the mesenchymal tissue into the neural tube before its formation. So that is the basic embryological understanding that we should have. So in a lipomyelocele, what happens is it is twice as common as lipomyelomeningocele. In both abnormalities, the intraspinal lipoma is a portion of a larger subcutaneous lipoma. So larger subcutaneous lipoma will be there. Additional to that, there will be intraspinal lipoma also, which this intraspinal lipoma extends into the spinal canal through a wide posterior spina bifida. So this is the way how to differentiate between lipomyelomeningocele and lipomyelocele. As I told, there will be a placode. Placode and lipomatous junction is the one that actually tells you whether it is a lipomyelocele or lipomyeloschisis, and it differentiates from the lipomyelomeningocele. If there is a spinal subarachnoid space here, which actually pushes the lipoma and the placode that interface outside the spinal canal, then it is lipomyelomeningocele. You need not have a meningeal protrusion like a CSF filled space to call it as lipomyelomeningocele. Where in such a scenario, only thing on the imaging, what you will be seeing is there will be expanded. This is actually a lipomyelocele. Here this placode and lipoma junction is actually within the spinal canal, and you can see this anterior subarachnoid space at that level is not very prominent. Whereas you come here in a lipomyelomeningocele, you are seeing this anterior subarachnoid space is quite prominent, and that is pushing the placode lipoma interface outside the spinal canal. This is actually lipomyelomeningocele. You need not have a meningeal protrusion containing the CSF space to call it as myelomeningocele in this closed spinal dysraphism. So lipomyelomeningocele is told. Hello. Yeah, I'll continue. So this is lipomyelomeningocele, where you are seeing that lipoma and placode interface is outside the spinal canal. But you may not be able to see actually comment on that. If the anterior subarachnoid space is prominent, you without any doubt you call it as lipomyelomeningocele. If it is not prominent, then it is lipomyelocele or lipomyeloschisis. So this is one more example of the lipomyelomeningocele. You can see that the placode and lipoma interface is outside the spinal canal and the prominent anterior subarachnoid space. Now coming to the myelocystocele, this can be either terminal or it can be segmental. What it actually means is it is an expansion of the central canal. If it is seen at the lower level, that is at the sacral level, it is called as the terminal myelocystocele, or sometimes it can be seen at the cervical level, where it is called as a segmental myelocystocele. Normally, usually what happens is there will be central canal which is dilated, which is surrounded by the pia mater, and this is surrounded by a dilated meningocele, that is a dural expansion will be there, which is containing the CSF. This dural expansion is lined by either the subarachnoid, either the arachnoid or the dura and the dura mater. So in a myelocystocele, especially in a terminal myelocystocele, you are seeing a expanded central canal surrounded by the meningocele. So this is how it will be seen, where the mass will be seen below the intergluteal cleft. So this is the picture I have taken from the net. So this is where the syringocele, that is the expansion of the central canal, which is having a meningocele that is surrounding it. So this is one example which we had, where there will be there is an expansion of the central canal here, which is having not exactly representing terminal myelocystocele, somewhat like that in an axial view. You can see there this expansion of the central canal may not be. I cannot tell that in this image there is a expansion of the means the meningocele are seen in this view as such. So this is one example of the terminal myelocystocele. And in a non-terminal myelocystocele, which is segmental, usually it is seen at the cervical level. There will be a large skin-covered meningocele with a thin neck crossing a narrow posterior spina bifida. Usually we see at the cervical level or at the upper thoracic level. And there will be expanded hydromyelic cavity lined by the posterior wall of the spinal cord in these cases. So this is one case of non-terminal myelocystocele. You can see there is an expansion of the central canal at this level, and this is extending outside. So you will not see a continuous track-like thing to call it as such on a imaging, but definitely there will be a track, and this entity is the cervical myelocystocele or a non-terminal myelocystocele. Coming to the meningocele is nothing but the expansion of the dural coverings, where usually it will be seen at the lumbar level or lumbosacral level, and it can be posterior, intrasacral, or the presacral, that is the anterior one. And they are characterized by the herniation of the CSF-filled sac lined by dura and arachnoid through the posterior spina bifida. By definition, no part of the spinal cord is contained within the sac when you are calling it as a meningocele. So this is one case of a meningocele, posterior meningocele. You are not seeing anything here except for the meningeal covering. And the way you can ask me how to differentiate this from the open spinal dysraphism. In an open spinal dysraphism, as I told earlier, there will be no skin covering, whereas here in this case there is a skin covering which is covering this thing. So that is a posterior one. This is the open. This is the intrasacral meningocele. You can see there is a dilatation of the dural sac, and there is no neural elements within this. So no neural nerve roots that are passing through the intrasacral meningocele. So with this, I will end up today's lecture. I will be talking about the closed spinal dysraphism with the refresher of some embryology in the next class. I am happy to take the questions if you have any.